welcome to our inaugural live AARC Perspectives Behind the Breath podcast series that highlights members who are making an impact in various specialties and avenues throughout the country. I'm Lisa Weisenberger, AARC Director of Engagement at Media, and I'm joined today by Monique Kimmel and Michelle Rowson to discuss what it's like to be a cancer care RT and what resources AARC has in providing support to RTs in these roles. Monique, do you want to start us off?
Sounds great. Thank you so much, Lisa. I'm Monique Kimmel, and I'm the Vice President of Membership and Customer Care at the AARC. And I'm proud to be and humbled to be joined today by Michelle Rowson, who is the Technical Director of the Respiratory Therapy Service and Pulmonary Function Laboratory at Memorial Sloan Kettering Cancer Clinic. That's a mouthful. And we're just so pleased that Michelle was able to join us today. And I have one more little mention is that Michelle was also part of the inaugural class of our a graduate of our AARC Emerging Leaders Program. So thanks again, Michelle, for being here today. Really appreciate that.
Thanks so much for having me, Monique. I'm really excited to be here and to talk with you.
So, Michelle, the title of today's podcast is A Day in the Life of a Cancer Care RT, something that we haven't covered a whole lot within the organization, and we're really excited to hear more from you. If you could tell me a little bit, what inspired you first to just be an RT in general, and then also how did you get into specifically cancer care?
Yeah, I'd love to tell you about that. It's a somewhat personal story. I was an undergrad at the University of Connecticut, and I was studying health science, and I was thinking about going into physical therapy. And I had a personal event that really changed the course of my life. I had a boyfriend who had cystic fibrosis at the time, and he was unfortunately a pedestrian hit by a car on New Year's Eve, and he ended up on ECMO, and he did unfortunately end up passing away. But I spent time with him in the ICU at his bedside, and I got to witness firsthand the respiratory therapist that cared for him both on the ventilator and that ran his ECMO pump. And that really changed the course of my life. I ended up finishing my undergraduate degree and then figuring out what it would take to become a respiratory therapist. That's what I did. And since graduating from my respiratory care program, I've worked in all areas of critical care. I even became an ECMO specialist. And then naturally, throughout the course of my career, I shifted into leadership. I received my master's in respiratory care leadership from Northeastern, which was a great program. And then, in the transition of my career, this amazing opportunity opened up at Memorial Sloan Kettering Cancer Center. And I actually found out from my father that my grandmother had actually been a patient at MSK. And, that kind of just really reinforced to me that it was the right step to take in my career, that everything really happens for a reason. And I don't know how many people remember this, but back in the day, you used to have a card with your name and your hospital ID on it. And my dad gave me my grandmother's card. And so I have my grandmother's MSK card in my wallet, and I actually carry it with me every day when I'm at work.
That's a great story. Thank you so much for sharing. You find that so often, don't you? Just that people come to a profession being based on personal circumstances and things that touch them in their lives. Thank you for that. So what brought you to the AARC?
I think like most of us, we join as students. We're really shepherded by our professors in our respiratory care programs to join as students and become student members. And that was true for me. And I've renewed ever since I was a student. I've never let my membership lapse. And I think it's really important to be a member of the AARC.
Thank you so much. Thanks for sharing that as well. So now kind of circling back to the title of today's podcast, what does a typical day look like for you as uniquely in your specialty in caring for cancer care patients?
So, while it's unique to care for cancer patients, there's also a lot that's similar, I will say. So at MSK, we are a standalone cancer hospital, and that makes us unique, but we're also an acute care hospital. We're a 500-bed hospital, and a lot of what we do is acute care. So our RTs come in, they get report for their assignments, they round on patients, they help out their colleagues, they get called to codes, rapid responses, they go on transports, they assist with procedures. But the big difference is really all of our patients have or have had a diagnosis of cancer, and there are different reasons that they're admitted to the hospital. Those can be cancer related strictly, so they can be the progression of their disease. They could be treatment related, so it can be drug toxicity, adverse reactions to blood products, or post op complications. They can be they can have nothing to do with cancer. They can be a comorbid illness like a COPD exacerbation, or they can be acute organ failure like septic shock or respiratory failure that you might see in any ICU. And really, our job is to help give these patients more time with their family or get them home.
I would imagine also in what you do, similar to what RTs are doing everywhere, that you have a lot of collaboration with the other medical professionals in your team. Can you explain or walk me through a little bit what that looks like?
Yeah, collaboration is really probably one of the most important aspects of caring for patients here. One thing that really struck me when I first started working here was that the patient comes first and that we are all on the same team with the same goal. Interprofessional collaboration and communication is just at the height of what we do. Our respiratory therapists are on hospital wide committees. Again, they participate in the code team. They're part of emergency surgical airway response teams. We participate in simulations. We recently opened a simulation center that we're really proud of. We're part of educating other disciplines. We educate fellows. It's really important that we are proactive in the care for our patients. We make sure we speak up on rounds and we provide a lot of education. So that's, I think, how we can best interact with other professionals.
That sounds great. And it sounds like you really are truly meshed within the fabric of the care community, which is fabulous. I'm sure, again, in your line specifically, that there are a lot of cancer treatments that are very challenging. How do you manage the emotional toll of having to deal with the patients and the families, in these during these really challenging times for them?
Well, we see a lot of end of life at a cancer center. I'd say, respiratory therapists in general deal with a lot of end of life. These are the situations that we're there for. But at a cancer hospital, we see a significantly more amount of end of life situations, and the emotional toll on that to staff is just exponential. So what we've developed at MSK is something called the SAGE team. Stands for Staff Assistance Guiding End of Life Resuscitation and Care. And what that does is it allows staff to call for the SAGE team to come and provide support for staff in anticipation of an end of life code situation. So the hope is that this SAGE team can preemptively prevent feelings of distress in the frontline staff that are going to have to respond to difficult end of life situations. Some hospitals have things called code lavender, and those are after a code blue. But SAGE team, SAGE being another name for a green color, is kind of on the rainbow spectrum, and it happens before a code blue. And so this is supposed to be support that's meant to kind of address the problem before it happens. And so this is really, really something exciting that we do to try to address the problem.
That is awesome. And in fact, that was a little bit of a promo, if you will, because I know Michelle's going to be joining us again next month. And there wasn't enough time right now to discuss this in full, but she's going to be coming back and doing a webinar somewhere in the last week of May. Keep looking at AARC News for more details on that and really going through a deep dive with the whole SAGE program. So, thanks for mentioning that. So we have something to look forward to learning a little bit more about in May. But in the meantime, I know that what, again, you do is you probably have so many of these types of stories, but can you please describe to us maybe a couple or one especially memorable experience that you had that, basically where made a really significant difference in someone's life or vice versa?
It's been a while since I've been at the bedside, but thinking back to when I was providing care, always the things where I felt like I was empowering someone to have a sense of control in a situation where they didn't. So things that stood out for me when I was a bedside care provider would be teaching families of pediatric patients who newly had tracheostomies placed, was teaching them how to perform their own trach changes. I worked in a facility where caregivers who were going to be home alone with patients with tracheostomies had to perform a certain number of trach changes before they were allowed to be discharged with a child. And so I would have to teach that caregiver how to perform the trach change on their child, and being able to do that and give that caregiver some sense of control in a situation where they had very little. Providing that education was always the situation for me where I felt like I made the most difference. And I feel like that translates incredibly well to what my staff do here every day with cancer patients, being able to provide any amount of education, any sense of control when, especially in cancer, it's a situation that you have very little control over. That to me makes the biggest difference. And also, the most memorable experiences that you can have with your patients are when you have some sort of personal connection with either the patients, their families, or a caregiver.
Powerful. And your mention of just being able to empower them, and at least they can feel as if they have some management somewhere in what's going on with them. Thanks for sharing that. What are also some of the unique challenges in respiratory care that you encounter with patients who are undergoing cancer care treatments? Chemotherapy, immunotherapy, radiation.
Yeah, so we have patients that have a lot of difficult airways, or patients may have unique physiology due to the surgical procedures they've had. Some have esophagectomies that can alter their airways. There are different ways to do those procedures. Some have tumor growth, which can certainly physically impede an airway. So it's really important that when our RTs are going in to see these patients, that they're mindful of specifically what anatomy our patients have. Patients are also often really weak and have less reserve, and that can affect ability to wean from the ventilator. Especially after having undergone radiation and different treatments, we see a lot of hemoptysis, so we often nebulize a lot of tranexamic acid to patients. We also see, we see complications from other immunotherapies and CAR T cell therapy, like cytokine release syndrome and ICANS, which cause a lot of respiratory compromise. And so those are a lot of the complications that we're dealing with in our ICU.
I would imagine on a consistent basis and varied. I mean, it's patient to patient, case by case. So wow, thank you. Thanks for explaining that to us. I know that there have been and there continue to be a lot of advancements in cancer care treatments. How has that, or how have any of these impacted or the way that you provide respiratory therapy to some of your patients?
I think some of the advancements mean that there are more aggressive surgical and interventional approaches to the treatment. So we're seeing sicker patients having more interventions than we used to before. So that means we're seeing a lot more patients have complications. Um, we're seeing more minimally invasive thoracic surgery, bronchoscopic debulking, more procedures done by interventional pulmonology, and that can lead to an increase in complex post-op care. And so we see a lot of patients having complications following these procedures. There's also an increase on, an emphasis on quality of life for patients, especially at the end of their life. And so we've seen a huge increase in using high flow nasal cannula at the end of life to alleviate dyspnea. And that kind of creates a conundrum for how do we get these patients out of the hospital? How do we get a patient that's on maybe 40 liters of high flow oxygen home on that device? It becomes challenging.
You know, you're explaining a lot about how this continues to evolve. What are you seeing sort of in the future? Are there anything that you're looking at more carefully or closely that could affect your ability to provide respiratory care?
I think one thing we're looking at is the use of telemedicine. At MSK, we've developed a telemedicine role in providing education in conjunction with our pulmonary clinics. And I'd love to develop that further and see where we could go with that. We use respiratory therapy driven protocols for bronchial hygiene. We'd love to expand on that. We know there's evidence for the use of respiratory therapy driven protocols and for value-based care. I'm very excited about the role of the APRT and seeing how that evolves and how we could potentially benefit from that and work that in. So there's lots of exciting things in the future.
It sounds like it. That's great. And it's nice to see that and to hear that too, that just the profession continues to grow and be enhanced with all of these changes that are going on. What are some of the changes or improvements that you would like to see in healthcare, especially in respiratory care for cancer patients?
I think one thing that I don't see happening routinely, at least in this hospital, is having respiratory therapy involvement in goals of care discussions and end of life planning, especially when patients are at our ICUs and those conversations haven't been broached yet. It would be interesting to see how we could kind of get a seat at that table. It would help us have more of a shift to be seen as partners in their cancer care rather than as responders to symptoms. I also think it would be beneficial to have more cancer related content in respiratory educational programs. I think that's something that is lacking, or at least when I was in school, did not have a lot of.
Yeah. And something that the AARC is looking to provide more of, more access to those resources. We just unveiled a new cancer care community on AARC Connect. It's open to all members. Hope you'll come on in and share that and share resources that you might have. So to Michelle's point. And sort of segueing into that, what are some AARC resources that you've found to be valuable?
Well, you mentioned ARC Connect. That is something, I have loved the ARC Connect. You mentioned at the top that I was a member of the Emerging Leaders Program. That was absolutely invaluable. I can't recommend that enough. So, if anyone is considering submitting an application for the Emerging Leaders Program, absolutely do it. Really, really love the clinical practice guidelines and the respiratory care journal. Those are great resources.
And I will say consistently at the top of our list when we ask members for their feedback. So right in line with what you're saying. I appreciate that. As we kind of close today's podcast, do you have any last thoughts for RTs who might be considering going into cancer care down the line, or if they're dabbling in it right now part-time?
Yeah, cancer care is a great place to make a difference as a respiratory therapist. 1 in 3 people are affected by cancer. So that's a huge amount of people. It touches almost everyone, and we need good RTs. And I know there are a lot of you. It's really important if you work in cancer care to remember why you got into this field. For me, it's honoring the memory of a loved one. It can be about the patients. There's all sorts of reasons, and it's important to lean on your support system, whether it's your colleagues, your family, your friends. And in this field, we need to embrace a bit of discomfort. There's a lot of difficult situations, but when you have a good team and you keep on learning, we really do make the most difference we can for our patients, and that's what it's all about.
Thank you so much, Michelle. And again, thank you for joining us today. We really appreciate that, and we look forward to learning more about this program toward the end of the month in May. So I appreciate that very much. Again, just a little shout out to the new cancer community on AARC Connect. Come and discuss and join and follow and learn some more researchers or share your own for everybody. And again, thank you. Really appreciate your time today.
Thanks so much for having me.
Thanks, Monique and Michelle, for joining us today. It's been such an insightful and inspiring conversation. And just a reminder to keep an eye on your inbox for details on the next live ARC Perspectives Behind the Breath podcast.